So good day to you, ma'am, and I hope the weather is fine today as you're watching this video or this presentation. So we, our group, Ayad Betito, Duremdes, Perez, and Villanueva will be presenting a case study which is preterm premature rupture of membranes. Okay, so here are our group mates, Mr. Ayad Nathan Scott, Betito Alberta Marie, Duremdes Carla Nicole, yours truly, Perez, Crisney Josephine, and Villanueva Toribio Jr. So, as you can see, I have your pictures of my group mates, and as we report later on about our subtopics about this case presentation, you see the pictures here at in the sides that will indicate who is reporting what. Okay, so our case presentation is, as I have said earlier, is premature rupture of membrane, and we had our client or our patient in Hospital ng Cabuyao in Laguna. Okay, so we'll start our demographic data.
Demographic data. Patient's name is Mrs. E, age 35 years old. Her birthday is on June 10, 1984. Her weight is 39 kilograms, with a height of 5 feet 1 inches. Her address can be found at 818 Gulod, Cabuyao, Laguna. Her significant other is her husband. The source of information for the data collected for this case is from the patient and the patient's mother. Her chief complaint is labor pains. History of present illness. At around 10 p.m. on February 19, 2020, Mrs. E started having a fever. At around 2 a.m. on February 20, 2020, the onset of labor pains occurred. And at around 6:30 a.m. the same day was when labor pains were followed by premature rupture of membranes. And around 7:50 a.m. is when her brothers brought her to Cabuyao Hospital. Past health history. The patient reported no history of hospitalizations or surgeries. Her medications included maintenance drugs like folic acid. Medications during hospitalization included IVF D5-LR, 1 liter for 8 hours, cefuroxime, omeprazole, metoclopramide, paracetamol, oxytocin, methergine, midazolam, tramadol, Dulcet tab, and Flanax. The home medication she was prescribed were Dulcet, Flanax, and cefuroxime. Major childhood and adult illnesses. The client reported to have reoccurring urinary tract infections from 2012 and 2015. The patient has no known allergies, and she has no history of blood or blood product transfusion. Family history. The patient's father is 70 years old with asthma, and her mother is 60 years old with hypertension. Her brothers have no known diseases.
Okay, so I am here and I will be discussing about the book picture versus the client's manifestations. So I decided to discuss first about the client's manifestation so that I could explain it more clearly about the book manifestations. Okay, so first of all, the client manifestations, the first thing is leukocytosis. So we could really see that there was a leukocytosis because as we checked the laboratory results, it showed that the day before she gave birth, or the day when she really arrived at the hospital, that time being, so it showed that there was a high amount of leukocytes, which is our white blood cells, and it showed a 17.60 10 raised to Q ml. So it's there in the paper, and the lab tests was taken at February 19, 2020, as I have said, the day when she was admitted into the hospital. Okay, so next is the sudden gush of fluid from your vagina or from the vagina of the patient. So this happened to our patient because, of course, that was the reason why she went to the hospital, because of the labor pains and because her bag of water ruptured. And the third is tachycardia. So also, when we checked for the data, we saw that upon arrival, that the patient had very very high heartbeat, and also she verbalized that time that it was that night that she checked her pulse rate, it was beating so fast. Okay, so now we will be now tackling about the book picture. So okay, so here we could see first is about the sudden gush of fluid from your vagina. So first of all, among the six of them, the client manifested 3. Okay, so let's talk again. So the sudden gush of fluid from your vagina, if you have premature rupture of membrane, all 6 of this should be present, or is really present, or is expected. So there, our patient also has a sudden gush of fluid from her vagina. Next is the evaluation of vaginal fluid alkalinity, or blue color on nitazine paper. So as you see there, there's a paper, a strip of with yellow portion and the blue portion at the end. So the yellow portion, that is the urine of a patient, and at the end portion, which is the blue one, that shows alkalinity. So if you have that kind of result, there's a big chance that you have premature rupture of membrane. Next is leukocytosis. Of course, a high amount of leukocytes or white blood cells, which also did manifested from our patient. Next is a positive Fern test. So what is a positive Fern test? So a positive Fern test refers to the detection of characteristic fern-like pattern of vaginal secretions when a specimen is allowed to dry on a glass slide and is viewed under a low-power microscope. So the Fern test, it is used to provide evidence of the presence of amniotic fluid and is used by doctors, specifically by obstetrics, to detect premature rupture of membranes. Okay, so that's it. As you can see, there's like fern pattern there. And then next is tachycardia, which also did our patient manifested. So of course, heartbeat very fast, and of course last is foul smelling. So you expect your vagina to smell bad, but you know what, we don't know that our patient didn't manifested this kind of signs and things, because of course, first of all, our patient didn't do a positive Fern test because she doesn't have money, and when she arrived there, they just took her CBC and then that's all. They didn't even took their adene test, maybe because of money issues. And of course, she also didn't had a positive what do you call that, vaginal fluid alkalinity. And of course we didn't ask her like, ma'am, do your vagina smell a lot? And we didn't even smell it. So there's a big chance that if we did this test, or if this patient really did this test, there's a big possibility that our patient might be positive. But yes, I don't want to say that it's positive because of course we didn't do it. Okay, so that's for the book picture versus client's manifestation.
Normal physiology. This figure shows the beginning of pregnancy until implantation. But as we all know, after fertilization, the human chorionic gonadotropin that is secreted by trophoblast cells causes uterine endometrium to continue to grow in thickness and vascularity. This time, the endometrium is now termed as decidua. By the 11th or 12th day after fertilization, the chorionic villi reach out from the trophoblast cells into the uterine endometrium to begin the formation of placenta. During the 20th to 24th weeks of pregnancy, the cytotrophoblast cells are no longer present. The cytotrophoblast cells protects the growing embryo and fetus from certain infectious organisms. If cytotrophoblast cells are not present, It increases the vulnerability of the fetus to viruses. The fetal membranes, the chorionic villi on the medial surface of the trophoblast that are not involved in implantation, gradually thin until they become the chorionic membrane. The amniotic membrane or amnion forms beneath the chorion. The amniotic membrane is a dual-walled sac with chorion as the outmost part and the amnion as the innermost part. When the two fuses together as the pregnancy progresses, they appear to be a single sac. They have no nerve supply, so when they spontaneously ruptured at term, or artificially ruptured via a procedure, neither the pregnant woman nor fetus experiences any pain. Also, in addition to amniotic membrane, it does not only offer support to amniotic fluid, but also actually produces the fluid. In addition, it produces a phospholipid that initiates the formation of prostaglandin, which may be the trigger that initiates labor. If after birth, the complete amniotic sac remain coating the newborn, this is called caul. It is different from the vernix. When seen in the light, the amniotic sac is shiny and very smooth, but tough. Once the baby is pushed out of the mother's uterus, the umbilical cord, placenta, and amniotic sac are pushed out as well. Amniotic sac and fluid cushions the fetus. It allows the fetus to move freely. Rupture of membrane, it happens during labor. The amniotic sac must break. It occurs spontaneously at full term, either during or at the beginning of labor. Premature rupture of membranes is a rupture prior to the onset of labor. The artificial rupture of membranes, also known as amniotomy, uses medical devices to break the amniotic sac, like amnihook and amnicot. Remember that babies can hang around for too long, sends amniotic fluid without risk of infection.
Okay, so I'm back and we will be discussing about the pathophysiology of the disease. So here you can see risk factors. So there are two, the modifiable and the non-modifiable. Okay, so let's talk about the non-modifiable risk factors. So here you can see that first of all, she's a female. Of course, we won't have premature rupture of membrane if you're not a female, of course. And next is age. So you are at risk of having premature rupture of membranes if you are 30 years old and above and you are pregnant. So here, our client is 35 years old. That's why it's a non-modifiable risk factors. Okay, so about the modifiable risk factors, number one is infection, because you could see with a high level of white blood cell that it indicates infection. So next, number two is low socioeconomic conditions. So of course, we did our assessment. We asked her about her personal life, and there we saw that she and her family has a low socioeconomic condition. Next is hygiene, specifically perineal. Why? Because you would ask why perineal? Because of course we assessed our patient and we asked her how does she do things, how she washes everything, and we concluded and it came to the result that she washes her vagina from back to front, and that is very wrong because it could cause urinary tract infection or other infection, right? So, and of course last is low BMI. She is 5'1" and she weighs 39 kilos. Okay, moving on. So I've discussed already the risk factors, which are non-modifiable and modifiable. Okay, so here, as you can see, the table there and the diagram here is the preterm premature rupture membranes. So as you can see, the etiology is multifactorial. So it means it's not only one thing that could trigger that. There are a lot of things, but they didn't put it since the only thing that we're sure of is infection. So it could be multiple pregnancy, antepartum bleeding, polyhydramnios, aminosynthesis, previous pre-prom, smoking, or low socioeconomic status. Since we can prove other things, the only thing that is really feasible is infection and low socioeconomic status, but we really put the infection, but however, in our case, when we check the the medical diagnosis, there was a thing there that says TC, or to consider chorioamnionitis. So there's a big chance that it is chorioamnionitis. However, we can't put it here in our paper since we lack information. And since the final diagnosis, it says just LTL, LTC, the transverse line cesarean section. That's the only thing. There were no chorioamnionitis there. So even though we have supporting details, we can't, since we also lack diagnostic tests. There are no other tests that could prove that it could be chorioamnionitis, only CBC. Okay, so moving on, here I have mentioned a lot of things. So because of that, it could trigger, so it could trigger this thing. So stress from complication activates inflammatory cascade, since there are a lot of things na. And then there you see the inflammation starts already, and you can see the high amount of white blood cells, which is the leukocytosis, and a fever which is 38.6 degrees Celsius, as said by the patient. And then of course, since there's an infection, this is where our prostaglandins enter. Okay, so it's because prostaglandins acts as signals to control several different processes depending on the part of the body in which they are made. So prostaglandins are made at sites of tissue damages or infection. So they are produced in nearly all cells and are part of the body's way of dealing with injury and illness. So since there's an infection, there's an inflammatory process that is happening, of course prostaglandins are there. And prostaglandins also, it causes our menstrual cramps, severe contractions, and may constrict the blood vessels around the uterus. So when a pregnant woman go into labor, prostaglandins helps cause the cervix to dilate and the contractions to occur. So that thing really makes sense of how did this happen, because there are prostaglandins released because of infection. It led to regular contractions and cervical change, even though it's not yet viable. So here, less than 37 weeks, and then after that, since there are regular contractions and cervical change, there you have your preterm premature rupture of membranes, less than 37 weeks. Okay, and since that happened, what happened to our patient is she had a cesarean birth, and after her cesarean birth, she is now well. However, here in the second thing, if there were no cesarean birth or anything that they would intervene with, it could lead to hemorrhage, and hemorrhage could lead to maternal sepsis and could lead to death. It could also cause chorioamnionitis and endometriosis, which is a complication. So that is all for our anatomy, and that is for our pathophysiology.
For the nursing process, first we have listed the prioritized nursing problem. First is the pain at the cesarean section. Second is grief. Third is presence of surgical incision. Now for the first problem, which is the problem number 1, which is the pain at the cesarean section, the subjective cue is client's report of pain on operative site with a pain scale of 6 to 10. For the objective cues are uncomfortable facial grimace, guarding of operative site upon movement, which is we cease upon assessment and when we are helping her with her binder, and also the binder on the surgical incision site. For the nursing diagnosis, it is the acute pain related to traumatized secondary to cesarean section as evidenced by the facial grimace with a pain scale of 6 to 10. Okay, for the knock, is the pain control because we want the patient to able to resist and to endure the pain of her cesarean, cesarean operation. For the short-term goal, it is after 4 hours of nursing intervention, the client will report a decrease in pain level from 6 to 10 to 4 to 10. For the long-term goal, before discharge, the client will be able to perform pain management techniques. Okay. Now for the nursing for the NIC is will be the pain management on how we could manage to decrease her pain for the short term and also for the long term. So for the independent nursing interventions is perform pain assessment, include location, characteristics, onset, duration, frequency, quality, intensity, or severity, and precipitating factors of pain. The reason behind that because pain is a subjective experience, it must be described by the client. So if the client can describe her pain more elaborately, we could plan more for effective treatment. Second intervention for dependent is encourage early ambulation. The reason for that because ambulation promotes normalization of organ function, similar peristalsis and passing of flatus, and also for the discomfort of her abdomen. Third is promoted and provided a rest period to give time for sleep and relaxation. And the reason behind that because one of the things that aggregate pain is exhaustion. So we want to make sure that the client will not exhaust herself or have a fatigue, so that we could able to give her more time to relax and it will provide her more rest. Fourth is encourage deep breathing exercise and educate the client about what is relevant to relieving pain. Because when in pain, the muscles tense, which is more cause more pain. So by breathing, it could give us reduces the muscle tension, reduces the pain, and giving the client more relaxed status. Next is instruct the patient to use relaxation techniques and encourage diversional activities such as listening to music, watching TV, meditation, and socialization with others. Because with these techniques, the client's attention will be away from her pain, which is she will focus more on what her doing, like from watching the TV, especially on meditation, and even socialization could help. And some techniques enhance the effect of the analgesic, and it will distract the attention and also reduce the tension of the patient. Now for the dependent nursing intervention is first you must provide optimal pain relief by administering prescribed pain relief medication. You can administer tramadol, which is 50 milligram IV every 4 hours, ibuprofen 400 milligram IV is Q6 of 4 doses, and home medication will be Docket, which is 500 milligram per tab or 1 tab by oral, which is for 7 days. Now, for the evaluation is for short-term goal met because after 4 hours of nursing intervention, the client reported a pain scale of 12 to 10, which is much more than we have expected. For the long-term goal, it's also goal met because prior to discharge, the client was able to demonstrate pain management techniques.
Hi everyone, my name is Toribio Villanueva and I will be presenting one of the nursing process for our patient that has premature ruptured of a membrane, and my part is the nursing problem number 2, which is grief. And for our patient's subjective cues, patient had verbalized that namatay yung baby ko pagkalabas sa tiyan pero nahawakan pa naman ng tatay niya bago siya nawalan ng hininga. And the patient also had went on indicating parang hinintay pa nga niya yung tatay niya. And for her objective cues, patient had a 32-week-old newborn which passed away after her CS. And then the mother also had a teary eye when asked about the loss of the newborn. For her the nursing diagnosis, which is grieving related to loss of a newborn as evidenced by mother's facial expression of sadness, which the patient had indicated or showing when we were asking her about the loss of the baby. For the rational and grieving, it's a normal complex process that include um, emotional, physical, spiritual, social, and intellectual responses and behavior by which individual or families um, incorporated an actual anticipated or perceived loss into their lives. Then for our nursing outcome, it's coping, family coping. And then the short-term goal is after 1 hour of nursing intervention, the client will be able to identify and express her feelings, for example, fear, guilt, or sadness freely. And then for our long-term goal, before discharge, the client will be able to look toward plan for the future 1 day at a time. And for our nursing intervention classification, which is emotional support, and then in our independent nursing intervention would include label patient's charts, room door, and or head of the bed as indicated. Rationale for this one is that it would alert hospital staff and volunteers so they are informed about the patient's loss. Now for our patient, she actually didn't have anything labeled on her bed or on top of her bed, and me and Kyla had to go into her charts to find out that she did lose her baby boy after her CS. Another intervention is discover the magnitude of the loss for both members of the couple, regard how strongly the couple desired this pregnancy. Rationale for this one is that the magnitude or weight of the loss is a factor in extent and duration of the grief response. Parents may feel a loss throughout their lives, mourning for the child that they will never know or watch grow up. And then another intervention is to assess the patient's couple information and understanding of events surrounding the death of the infant, which if the rationale for this one is that emotional reaction may prevent the couple's ability to process information and interpret the significance of the event. So you would need to know how ready they are to listen or to address this issue. And then another one intervention is recognize the states of grief being displayed. For example, denial, anger, bargaining, depression, and acceptance. Then use therapeutic communication skills. For example, active listening, acknowledgement, respecting the patient's desire, request not to talk. The rationale for this one is that if the process of grieving is not completed, grief may become dysfunctional, resulting in behavior that are disturbing to personal safety and to the future of the family or the relationship. And then another intervention is reinforce the family's expression of feelings and listen, remaining with a calm or commenting as appropriate to the patient, and then also observe the body language and then promote the relaxed atmosphere for the patient. Now, for this one, it's I kind of feel bad for the patient when we saw her that she was in the room with the other mothers that has or breastfeeding their baby, and she was there, and also there's some babies that's crying. Which if there is an extra room, the patient should be in a room where she could be just herself and process the loss. And then another intervention is observe the patient's activity level, sleep pattern, appetite, and personal hygiene. Knowing that when patients are in the press and they're still grieving, sometimes patients lost an ability to eat, lost their appetite, and then their activity level will be low, and then personal hygiene is neglected. So just watch out for these cues. Now, for the dependent nursing intervention, administer antidepressants medication if ordered by the medical doctor. Examples for such medication is fluoxetine, Prozac, or Celexa, Zoloft, or escitalopram, which is Lexapro. Now, for this class of drugs reduces symptoms of depressive disorder by correcting the chemical imbalance of neurotransmission in the brain. For our patients, she was indicating any depression or or any anxiety, so the doctor had not prescribed any of this medication. For our evaluation, which is the short-term goal, which is goal met, after 1 hour of nursing intervention, the client was able to express her feeling of sadness about the loss of her child. She had a tear eyes when we asked her how does she feel about the baby being lost. And then also for the long-term goal, it was actually goal met also. After we finished our interview, and then before we got to leave, we asked her about how her coping mechanism was, and then the client put up a strong face and said that she will be strong for her family, and then she was just gonna focus her role as a mother for her two boys that waiting for her at home. And then she said that she'll be fine, or they'll be fine. This is my presentation, and thank you for listening.
Now moving on to the last problem, which is the problem number 3, the risk for infection. So for the assessment is subjective. Patient verbalize, may tayo ako sa tiyan at may naramdaman ako na kirot pag namatayo at tumupo ako. For the objective is patient underwent a cesarean section delivery. Patient had a 4x4 gauze over her cesarean surgery under her binder. For the nursing diagnosis, it is a risk for infection related to tissue disruption. The rationale behind the diagnosis because risk for infection is one of the most common problems of individual where there's an alteration determines in immune defenses. So we all know that the skin is the first layer of defense against infection, microorganisms. So when it's destroyed, it could be a major problem, which could be a risk for infection because this infection could enter through the body, through the skin, and even the wound could get infected. For the knock, it will be the immune status. For the short-term goal, it is after 1 hour of health teaching, patient will verbalize understanding of individual causative or risk factors. So we want the patient more to understand on how she could prevent the infection. So health teaching will be the most effective way on how to help her on the infection of her cesarean section. For the long-term goal, it will be before discharge. The client will demonstrate techniques, lifestyle changes to promote a safe environment. For the NIC, it is infection control. So these are the following interventions that we could do for the patient. First is observe for localized signs of infection at surgical incision. So when we observe the wound or the incision, the earlier we could detect the sign of infection, the earlier also we could provide the intervention on how we could prevent the infection, because wound infection may be defined as a presence of bacteria or other organisms which multiply and lead to overcoming of host resistance. Infection can disrupt healing, so when the healing is disrupted, it could take much more longer time for the patient to have her skin healed back to the way it before, and it may also most more problem if there will be an infection. Second is assess and document skin conditions. It is essential that ongoing process of assessment, clinical decision making, intervention, and documentation occurs to facilitate optimal wound healing. So we want to make sure that the wound is healing over time when she is under our care or when she is discharged. So we want to make sure that the skin will be more intact and to prevent further infection. Educate patient on hand washing technique. So we all know, even not a non-medical person, know how important hand washing could be, especially for her, to our patient, when she had this incision in her abdomen, that avoiding touching and even avoiding microorganisms transferring. So the more effective way of preventing the transfer of microorganism is having a clean hand, which is by the use of the hand washing technique. Now next is increase oral fluid intake. So by the increasing of the fluid intake, it will let the patient urinate more frequently, as it is to flush away the microorganisms present in the body. Okay, that's how also um, oral fluid intake could help in preventing the microorganisms. Now, dependent nursing intervention could be administered ceftriaxone, which is 500 milligram per tab, or one tab 2 times a day for 7 days as doctor prescribed. When prescribed as antibiotic, it is extremely important to take a full dose for as long as doctor prescribe it, because you don't want to stop at the midweek or for the mid time, because if you stop during those times when you are taking the antibiotic, the microorganism or the bacteria, the virus could be much more resistant to the medicine, which will be much more harder to cure, what could affect the infection. Now, for the evaluation, for the short-term goal, is goal met after 1 hour of health teaching. The client verbalized understanding of individual constitutive risk factor by stating the right answers. So, we are surprised on how our patient can easily answer or understand on what we taught her about the risk factor, because it's important to her, because it will prevent further infection, and it could also promote her easier healing over time. So that is one of the what makes us happier in intervention with her. For the long-term goal is not evaluated, because we want to focus more on the environment, and we could not further assess that, because the patient is being discharged in the day, and we do not know if she could able to change her lifestyle or the environment and assess further. So that's all for the nursing process, and
Okay, so thank you, Nathan. And I guess that is all for our group. And I hope that you did understand our case content presentation. So questions are now ready to be answered. Thank you.